Hi everyone, we are the Gold Star Solutions consulting team consisting of myself, Lily Gia, Nick Rebald, Kenneth Chu, and Sarah Riziki, and we're really excited to be here today. So what we have for you, on your iPads we have two handouts. The first is an appendix which details the cost-benefit analyses for each of our recommendations that we plan on implementing. And the second handout is a brochure, is it a type of patient education material we plan on providing the beneficiaries of the South Tree Health Network. And it'd be really great if you could follow along with the appendices to assist you throughout this presentation. So we're going to start out with is an overview of the presentation. First, we'll start out with the introduction to the problems we saw in this case. We dug deeper with the root cause analysis to determine what caused the stroke in the first place. And through these root cause analysis, we have recommended the best interventions that will create a sustainable and efficient model to put South Tree Health Network in the forefront of the solution. So let's talk about stroke nationally. Stroke is a significant economic burden on the United States every year, and it affects almost 800,000 people in the United States annually. It is the leading cause of long-term disability, and it costs the United States $34 billion every year in direct costs such as medication and medical services, as well as indirect costs such as loss of productivity. So Kentucky in particular is an especially burdened region. It's in the stroke belt and it has one of the highest incidences of heart disease and stroke mortality in the United States. And we found that this was attributed to the underdiagnosis and undertreatment of modifiable risk factors such as eating more healthily or getting more exercise. And in particular, Kentucky, 40% of stroke survivors in Kentucky are under the age of 65, which is a particularly young demographic. And that we are targeting in the South Tree Health Network community, and as you can see, they're outlined on this map. So our mission for the South Tree Health Network is to recommend interventions that transform the already existing infrastructure of the South Tree Health Network to provide better quality of care, reduce preventable complications, and reduce the overall incidence of stroke. And so now Nick will talk about why our solutions come at a particularly exciting time in the healthcare landscape.
Our solutions come on the heels of the enactment of the Affordable Care Act, which was passed in 2010. And there are three major provisions that help to increase a newly insured patient population. There's the Medicaid expansion, which Kentucky implemented in 2013. There's the subsidies for private insurance and the health insurance mandate. All three come together to provide better access to care for this newly insured population. And we want the South Tree Health Network to be their providers and bring them into the healthcare system to provide better care for them and better population health. The Affordable Care Act also incentivizes the creation of ACOs, or Accountable Care Organizations, and we want South Tree Health Network to become one of those organizations focused on integrated providers and preventative health. And once we focus on all this, we can get these people into our network and provide the best care that we can. We want to focus on the triple aim for our solutions, which is improving patient experience, reducing the cost of healthcare, and improving population health. With this framework in mind, we've developed a set of goals using the triple aim. To improve patient experience, we're going to create a consistent patient experience across all STHN providers, making sure to increase patient satisfaction by 30% within the first 5 years. To improve population health, we're going to reduce stroke incidence in the region through the implementation of our two-phase plan, lower stroke risk factors in the STHN network through improved patient education and successful implementation of our solutions. We also plan on reducing the cost of healthcare in the region, making sure to maximize our resources and reduce the CMS penalty that we see levied on many of these providers. And I'm going to turn it over to Sarah for a root cause analysis of the problems.
So in order to identify what are the major sources of the stroke population in the STHN network, we looked at the typical journey a patient takes through the healthcare system. So first, a patient presents to the ER with stroke symptoms. They're administered TPA if within the allotted window. They're admitted to the hospital for further workup and evaluation. Once they've started the journey of recovery, they're discharged to an outpatient rehabilitation facility, and then they are sent home to finalize the recovery through continued monitoring of care. But we know this is obviously not a smooth transition, which is why we're here. So we try to figure out first, why are we even having strokes in the first place? Well, we looked at the patient and we found that there's a low health literacy in the Kentucky population. They're not aware of the risk factors that increase their chances of stroke, which leads to poor lifestyle choices. We also saw that there is a general sense of self-reliance. They feel that if they feel healthy, that must mean they are healthy, but we know that's not necessarily the case. In the inpatient setting, we found that there are several medical complications that could be avoided, mostly due to poor communication, both with the patient and between providers, which leads to a poor transition of care, which is further exacerbated by the fact that the EHR systems that are used are inconsistent and are unable to communicate with each other. We found that there's a lack of staffing in the outpatient setting, which inhibits proper delivery of care. And when the patient arrives home, we found that they are not supported as well as they should be, which leads to increased fall risks, medication errors, infections, and an overall decreased standard of living. So we've narrowed all of these down into 3 major root causes. First, we have an in general high stroke rate. We have a high readmission rate once a stroke has happened, and an overall poor patient satisfaction throughout the journey. So now Kenneth is going to talk about how we suggest on addressing these barriers.
So phase 1 of our 2-phase solutions focuses on transforming the system. That is, improving the quality and outcome of care for a patient after the stroke has happened. And this includes EHR integration, the stroke care pathway, and workforce development. In 2009, under the HITECH Act, all providers and hospitals were required to switch over to EHRs. In 2009, Kentucky also set up their Health Information Exchange, which is basically a central database where providers can upload their information and everyone else within the exchange has secure access to that information. In 2010, the national government started setting up the Direct Project, which allows providers to send patient information directly from provider to provider, even across various EHR systems. And so what we're doing with the integration is leveraging the existing infrastructure and having all the hospitals within the system join the exchange and take part in the Direct Project. And with that, we can have better transitions of care. On the inpatient side, we have the stroke care pathway. It's a set of clinical protocols using evidence-based guidelines to assist in decision-making, and this is done across an interprofessional team. So basically what it does, it takes all the moving parts that are happening during a patient's stay and uniting them in a system of checks and balances. And overall, we're hoping to improve communication, improve patient education, discharge planning, all while minimizing complications. And this system is already in place at University of Kentucky, and we would look to expand it to all the other hospitals within the system. And so here is an example of a stroke care pathway from Cleveland Clinic. As you can see, it addresses the various events within a patient's stay, and it follows the patient from admission to discharge, and it would address all the providers that interact with the patient during their stay. And now for a more outpatient setting, we're looking at workforce development. Basically, we would utilize the students in the community and have them interact with patients who have been discharged from the hospital. And this would address the lack of staffing for the outpatient community, as well as assist them in their recovery after their discharge from the hospital. And for the students, it enhances their education by allowing them to engage with the community, and in the long term, by working with the rehab services and with preceptors, they'll feel more comfortable and stay long-term after their graduation, therefore developing the workforce. And so here's an example of a home health team. We would have students from the various colleges and community and technical schools, which are shown in black boxes, go to patients who are in their region, and they would be overseen by preceptors. And so for the students, you would have better education as they would learn how to do things such as patient education and discharge planning. And then for the patients, they would have more continuity of care and better support. And I'd like to refer you to Appendix 2 for an example curriculum.
So phase 1, like Kenneth mentioned, focuses on improving care after a stroke has happened. Phase 2 focuses on preventing the strokes to begin with, and this is targeting the patient itself. So the first component of phase 2 is a mobile screening program. STHN already has such a program, but we plan to revamp, revitalize, and rebrand this mobile screening program, labeling it as the Health Screen Machine, which offers blood pressure, blood sugar, and cholesterol screenings. It can be tracked on this website to see where it goes next. It'll be stationed in 5 of the STHN member cities. It'll run every weekend to local fairs and festivals, maximizing exposure and reach. Each bus will be staffed by 2 LPNs and 2 social worker interns who will provide screenings using a handheld cardio check and blood pressure device. They'll provide risk assessment and counseling. This is a sample layout of the bus. The patient will enter. There will be a private medical screening area where such education and counseling will be given privately. There's a sample education material in your provided materials on your iPad for cholesterol, for an example. And what sets this program apart is that we will be able to directly link patients into the STHN network in real time using a mobile phone app that allows for scheduling. The second component of phase 2 is a marketing campaign. It's a print campaign. We want to focus on changing that idea that a physician is only used for sickness. We want them to see them when they are well as well. So we will hang these posters that say, your doctor wants to give you a gold star too. Visit your doctor today and show off your numbers. And we would like to have patients, when they see this poster, remember the pride that they had in their achievements when they were young and realign that pride with their health care and shift their view of the provider not just as a disciplinarian, but more so as a motivator, a companion, a partner in their health care, and a partnership. We would hang this poster in local shops, businesses, barber shops. It would run in the Sunday newspaper, and this would target not only the newly insured population that has been introduced through the ACA, but also patients who are already established with a primary care physician who may not be using them to the full advantage.
So let's revisit our root cause analysis and see how our solutions stack up to the problems we faced in the beginning. So to address the problems of poor communication, poor transitions of care, and lack of staffing, we have integrated the EHR system, developed a stroke care pathway, and also started a workforce development program. And as for phase 2, which focuses mainly on the prevention of stroke, we have started the health screen machine as well as the Gold Star marketing campaign. And hopefully through our 2-phase plan, we will reduce the number of strokes, reduce the number of 30-day readmissions, and overall provide better patient satisfaction. So for implementation, as far as how long it's going to take, so phase 1 will be implemented over the first 3 years, with phase 2 following the 2 years after. And we're going to start assessing the phase 1 at the end of year 2 and phase 2 by the end of year 4. So overall, it's a 5-year plan, but we all know that this is you have to continually monitor and make sure things are going smoothly. So we will continue monitoring after the 5 years are over as well.
So now you might be wondering how we're going to measure the success of our solutions. We've developed a set of metrics to make sure we stay on point. To improve patient experience, we're going to be using the HCAP score, or Health Consumer Assessment of Healthcare Providers and Systems scoring measurement system, which is how patients measure satisfaction of the providers they interact with. We aim to increase this by 30% within the first 5 years, bumping it up from a 63 to an 81.9 after 5 years. To improve population health, we aim to reduce stroke by 10% by the end of phase 1, making sure to improve education in the system by then. And we also plan to stay on track to reduce stroke incidence by 30% within 10 years. And we're going to use these numbers to also look at the stroke risk factors, making sure to bring these down to and past national averages, making sure we have patient education going effectively and our solutions are proceeding as planned. And we reduce the cost of healthcare by looking at the Medicare reimbursement. The reduction we have in the Medicare reimbursement rate will be at least 1% by the end of the first 5 years.
So to assess our financial impact, we created a cost-benefit analysis. The EHR integration and stroke care pathway costs $880,000. This is in professional development and training. And then the workforce development is over $1 million in percent effort for preceptors. The EHR integration will bring in just over $1 million, and this is mostly in prevented unnecessary admissions. And between the stroke care pathway and the workforce development, we bring in $600,000 in preventable complications, and then $4 million after 3 years, which is the Medicare reimbursement prevention from 3% to 2%. And then in phase 2, we have our mobile screening and the Gold Star campaign, which is close to $400,000, but brings back about $1.5 million. And if you look at appendices 2 through 4, there's a detailed breakdown. I'd like to point your attention to especially Appendix 5, which is a graph similar to this, a table similar to this table here. And what that is an outline of our basically bread and butter. It's what we have with the system itself. And this table is including the mobile scheduling app, which is kind of the icing on our cake. So we created a 5-year income or savings estimate. In the first year, we have investment into phase 1, which does leave us with a $300,000 deficit. But in phase 2, we more than double the return on our investment. And in year 4, when phase 2 rolls out, that's when the Medicare money comes back and we're able to fund phase 2, and then phase 2 brings in its own savings. So over 5 years, we're able to save over $12.5 million. And so with our partner with Bluegrass Blue Shield, we've decided to go with the shared savings plan because their incentive metrics lines up with our goals. And this way, by using the shared savings, we can focus on our results and achieve what we want while getting incentivized to do so. And you're able to focus both on the inpatient setting and the outpatient setting and primary care. And so one weakness may be that we lose sight of other aspects of patient care, such as patient satisfaction. But with our stroke care pathway and our workforce development, the system innately has these checks and balances in place so that we don't lose sight of any aspect while we're focusing on our results. And looking forward, South Street Health Network has indicated that they want to become an accountable care organization. And our two-phase system helps them move from a clinical integration network, which focuses more on improving provider performance, into an ACO, which focuses on population health. And as an ACO, they would then be eligible for the Medicare Shared Savings Plan, which should generate an additional $1.5 million, adding to the sustainability of our program.
So in summary, we at Gold Star Solutions are confident that the plans we've outlined for you address all of the barriers listed for the South Street Health Network stroke population in an efficient and effective manner. Our two-phase plan, first of all, focuses on the system itself, improving the care of a patient throughout the system after having a stroke. The second phase focuses on bringing the patient back into the provider's offices. And through the implementation of this plan, it embodies the triple aim, which is improving patient experience, reducing costs, and improving population health. And we know that South Street Health Network, by following through with our suggestions, will be able to provide a quality, patient-centered care for years to come. So thank you very much for your time. If you have any questions, we'd be happy to answer them.
Okay, well done. I didn't say this in the beginning, but congratulations. You guys made it, and you did a very nice job. And we really appreciate you all hanging out and sticking with us. I really enjoyed your presentation, so thank you. I know you put a lot of effort into it, and I think to me it really showed in your presentation and the amount of work that you've done. So I just had a couple questions. So the EHR, so explain, what are you recommending that we do with EHR? I know that you're saying we need to put some money into it, but specifically, what do you all, I might have missed that, what do you want to do with it?
So with the EHR, we want everybody on the Kentucky Health Information Exchange. They have the database, and you would need somebody to take the patient information from the EHRs and send it to the centralized database. And then by having the information there, they become part of, I guess, the Exchange Club, and they can access the information from other hospitals within the exchange. And so that's like a way to unite the network without having to, overhaul everybody's EHR or create an exchange on their own, which is very expensive to do.
Okay. So the Gold Star campaign, I thought really very creative. I like that. Did you all look at? I might have missed it. Maybe social media, any other? Is it a marketing campaign? Is really
Sure.
what we're talking about, right?
Yeah, exactly.
Okay,
Yes,
so
it's a marketing campaign.
yeah, so
we wanted to start with print first. We figured that would be more cost effective. If developing a marketing team would be involve more resources, and potentially the demographics in the Kentucky population may not be as adept in using social media as, say, other communities in the United States. So we figured that we would have a better reach with a print campaign than social media.
Okay. The last question I had was around the ACO. So I think you guys mentioned that as a health network, we were interested in going that way. I guess did you all consider any other type of scenario other than the ACO, or was that? I mean, is that something I guess you support?
We wanted to focus on developing the network, making sure it's more integrated first, focus on preventative health, and we would eventually see it become an ACO. But we know we can evaluate as we see the process develop, but we mainly focused on the ACO, and through pilot programs from the ACA, we can obviously gain more sustainability through the program.
You talked a bit about knowledge transfer tools, methods from the University of Kentucky. Do you think that the community hospitals and smaller groups will accept information flowing out of a academic medical center?
I think it would have to be tailored to the resources that each smaller facility offers. But given that everyone is involved in the South Street Health Network itself, unifies all hospitals with one another. So, but I think the biggest thing that we would have to be aware of is the resources that each facility offers.
So you think, given the structure, the fear of being gobbled up by a big center or having standards imposed that are not consistent with the culture or the practice would be mitigated and you can work through it?
So with their joining the South Street Health Network, they've already made an agreement to be part of a team. And our solutions use evidence-based examples. So all the numbers we have are based off studies that show if you do this, you'll get reimbursed. And the idea is to become an ACO and cut down on these things and be rewarded financially. And so we would try to incentivize them with those reasons, saying, hey, it's worked before, this could work for you. And then, of course, talk to them, get to know what they want, and compromise along the way.
Good answer. Yeah.
Oh, true. I mean, in addition to, I think what's nice about the stroke care pathway, they are guidelines and suggestions, and they are evidence-based, but it's obviously, we can't force anyone to do what, is in the protocol. So it offers a little bit of flexibility in how you want to tailor it to the facility you are at.
So the electronic health record, you put a lot of emphasis on that, and the evidence is still pretty thin out there in terms of what the return on investment is and really improving care. What do you think about that?
So,
do you think it's worth it for us to invest like that?
Yeah. So the cost is in training and professional development, and the integration, there was a study that went across several ERs and showed that those who had access to Exchange and were able to access patient encounters from other hospitals saved what we showed, which was a little over $1 million. And that's in preventable admissions and just unnecessary CTs and things of like. And I worked for 2 years in the ER as a scribe, which is basically typing for the doctors and doing the paperwork. And aside from the admission, the amount of money you save from needlessly admitting people, there's a lot of time and effort spent just running around trying to get things, find things, and then they fax it over. You get a stack of paper that's like 2 feet high, and all those are resources that we could save and better use for other things. And so I think the EHR implementation is a very important factor in our process.
I had one last question. Did you test the market about the acceptability of a more childlike scorecard with stars?
That is in the works. We are running that by our
Has some
control group.
Focus groups?
Focus group, yes.
Okay. Thank you.
You're welcome.
Nice job. Nice presentations.
Thank you.
What in phase one you talk about care and care protocol starting in the ED, but how about pre-hospital care with the EMS system, and what would is there anything that can be done to improve the community education is a huge piece of this, and I happen to like this Gold Star idea a lot. But as far as dealing with education and training of EMS providers and paramedics, what might you offer? I mean, these are a lot of rural, mountainous areas or difficult areas to get into. Any suggestions there, and any arrangements with EMS providers or air transport to the University of Kentucky if patients need more endovascular intervention than these community hospitals can provide?
Right. Well, we wanted to focus on the critical need of the physical therapists and the OTs in the region with our workforce development program, but we know we can expand that to include paramedics, training for the EMS professionals, get them into the system, educate them, and help to improve the protocols between ambulances and where the SDHN providers are. So that's just one way we thought of expanding our workforce program.
And just speaking to the stroke care pathway, I think there's so many errors going on within the inpatient setting now. We're going one step at a time, and we saw the most critical step being there first. And then, with the EMS system, there are a lot of other challenges, such as just distance from patient home to hospital, and that's just something that I think is beyond the scope of what we're able to focus on right now. And so we're trying to make the most critical changes for the biggest problems we see right now.
Any other questions?
I have no other questions.
Tom?
Yeah, one more minute.
Okay.
I don't have any other. Okay. All right, feedback time. So again, well done. I think overall, the just the presentation, kind of the blocking and tackling, I thought was really really good. Fundamentally, you guys seemed very strong as a team. You played off one another nice. I really like the fact that you didn't look at the screen behind you. It's kind of like it wasn't even there, which I think is great. So I appreciate you going to those lengths. I know that doesn't come easy, right? You got to practice. So I really appreciate you all doing that. Overall, just I thought the presentation was thoughtful. Just the way you had it set up and very concise. And so as a board member, just maybe I'm a lay board member and I don't know a lot about healthcare, it was very clear to me and easy to connect the dots as to what you all wanted to do and what you were recommending to us as a board. So I thought that was great. The flow was good. Just personally, you guys look calm and confident, which is always good. So I appreciate you guys doing that. And to me, maybe you weren't showing it, huh? I mean, it was very confident. And then to me, it was apparent that you guys were. I was convinced that you were subject matter experts. So I think that's good as well. And then I think you did a really nice job with the Q&A. So just overall, from a present standpoint, really good. Some of the things that I liked, the goals I thought were very clear and concise. In particular, I liked there were some aggressive goals as well, but they appeared to be doable. I really liked the patient satisfaction increase of 30%, I think was the number. I thought that was pretty strong. Really good statement there. Your method in identifying the 3 core issues, I thought that was very sound. The phased approach, obviously, we like that because there's a lot of things that you guys are recommending for us, and it's nice to be able to kind of chunk them up and go at them that way. So again, I thought all that was good. And then I'll finish the metrics of success. I really thought that was impactful as well. It's clear and it appeared to be achievable. So again, well done.
Great, thank you.
Good job all the way around. I think in 20 minutes, it's sometimes it's difficult to. I'm sorry, I'm getting over a respiratory thing. I'm sorry, my voice is so difficult to listen to. But I think it's hard to know what to include and what to exclude. You did a very nice job of giving us an appropriate amount of detail in the time you had to present. I like the documentation in the appendices. That was unusually well done, I think, and we appreciate that. I like the Gold Star program. I can relate to that. It's the boy in me, I guess, but
Yeah,
I like that. It really makes a lot of sense, and I think that might be well received by the community. So good work all the way around. Nice presentations, no reference to notes, and you clearly have interest and passion in this, so good work.
Thank you.
Thank you.
Well, I join my colleagues in commending you on a fine presentation. It was very well done. Just a couple points that I'd like to emphasize. Your selection of slides and the presentation of them was very crisp, very clear, and spoke well to us as board members in terms of, I think someone said you connected the dots, and there was a great flow of logic that was easy to follow. Starting off the presentation, I think orienting us to what to expect and your reference to the materials was very helpful and helped calibrate my attention. The context of the ACA is both timely and important. That was helpful. And you define the triple aim. So, sometimes there's an assumption that everybody knows. We live it, so we know it, but board members may not. The goals were well organized and clear, both process and outcome. I think having that mix is important, and they were enough of a stretch that I got the sense that we'd have to do some heavy lifting, but that in the end it would be achievable. And that's kind of where you want goals to set.
Yeah.
So well done on that.
Thank you.
Had some nice innovation in there with the screening, the mobile screening, and the campaign. And while I asked a question that could have been seen as negative toward the gold stars, I do think it may tap into the population and the communities that you're talking about,
Yeah.
something tangible and clear and pretty straightforward. You presented as a very strong team in command of the material, poised and confident, and clearly worked with each other in a very unassuming way to make sure that people were speaking up and there was balanced presentation. And the implementation in your presentation was well designed. There was just one little chink, and this is my bias, but at one point you referred to the patient as it. And objectifying the patient, is
Honestly?
always a problem.
Yeah.
Yeah.
Sure.
Yeah. So just,
Yeah.
take care with that
100%.
one.
Yeah.
Yeah.
Thank you.
But actually, it didn't detract from the overall,
Okay.
and I'm particularly tuned into
You're
that,
right.
so others may not notice that at all.
Yeah.
But very strong presentation. Thank you.
Good feedback.
Thank you.
Thank
Thank
you.
you so much.
Thanks.